Very much. First of all, I want to thank you very much to Dr. Sparges and Dr. Patakos for their kind invitation, and on behalf of Turkish Working Group of Interventional Cardiology, I bring all my greetings from our executive board to our friends, Greek friends. So a lot of things are discussed before, but I will try to make a short presentation. A lot of procedures we know that were done with old generation valves, and we have got important lessons learned from the old generation devices. One important lesson is, yes, TAVI is a revolution therapy in the elderly and high-risk patients with severe aortic stenosis. So all the studies show that in high-risk patients, TAVI is superior to surgery. I can say this, in patients with high risk. But the survival benefit was only found with transfemoral femoral TAVI and appeared more pronounced in women than in men. And so we have got important lessons learned from the old generation devices, that TAVI is also not an innocent procedure. There are some procedural complications: annulus rupture, coronary occlusion, ventricular rupture, device embolization, and early periprocedural complications, paravalvular leak, pacemaker, vascular complications, stroke, early valve thrombosis, and during the follow-up, the durability is also an important issue. But when we look at also to the risk scoring systems for TAVI, everybody knows STS, Euroscore, and Logistic Euroscore, but fragility is not indexed in this score. And chest deformity, malnutrition, porcelain aorta, liver disease, previous radiotherapy. So I think a specific TAVI score must be done before the evaluation of these patients. When we look also the randomized clinical trials, mean age is actually at 80. And limitations of risk scores. Let's look at this example. 85 years old man, severe aortic stenosis, no risk factors. We all know that STSF score is 1 point, and this patient go to TAVI in many centers. In real practice, what we understand from low risk, old and young patients. So what is the limitations of surgery in patients with older age with low risk? Actually, I didn't bring the meta-analysis to this presentation, but you can find all these meta-analysis from the literature. So limitations of surgery in old and low risk patients, there are some procedural limitations. 1, duration of hospitalization. 2, cost effectivity and risk of heart development of heart failure. And early periprocedural, new onset atrial fibrillation, bleeding and renal failure, and follow-up patient prosthesis mismatch. We all discussed in the morning. But limitations of TAVI in young patients, I underlined again, annulus rupture, risk of coronary occlusion, risk of ventricular rupture, device embolization, and also during follow-up, coronary reaccess, durability, and valve-in-valve TAVI. And we never forget that bicuspid aorta and aortopathy in these patients, because a lot of a lot of randomized clinical trials, these patients were excluded from the studies, patients with bicuspid aorta. So when we look into the studies, which is compared to the TAVI versus surgical aortic valvuloplasties, when you look at the risk scores, yes, TAVI is superior, but when the risk score decreases, TAVI is equal to the surgery. It seems equal. So there is a tendency now to do TAVI in young and low risk patients. But anatomy must be transfemoral, and paravalvular leak mild, okay, we don't know. We don't know that. We know left bundle branch block or pacemaker benign, prosthesis patient mismatch matter, and coronary access for coronary artery disease straightforward, and lifetime management of aortic valve disease very important. So what is important if we will TAVI to low risk and younger patients? Safety is deferred. We must end the procedure with 0 stroke, 0 complications, and early recovery with no long-term adverse events, and lifetime management very important, good hemodynamic results, durability, and providing the ability to perform redo-TAVI in these patients. So I will only speak about 2 randomized trials, about their 5-year clinical and echocardiographic outcomes. As you see, one is the partner 3 study, 1-1 to randomization study, and primary at one endpoint at 1 year was composite of all-cause death, all stroke or rehospitalization, and 91% of patients available for primary endpoint analyzed at 5 years. And these 5 years show that TAVI in low-risk patient, the endpoints are lower than surgery. So this is a very important result of this study. When we look at the cardiovascular death rates were similar. And additional clinical endpoints are very important. New onset atrial fibrillation is higher in surgery, and serious bleeding is higher in surgery. Valve thrombosis is an important issue, especially in TAVI patients, so we must be careful about reduced leaflet motioning and hypoattenuated leaflet motion. And the early experience of our surgeons, that when they put a bioprosthetic valve in a patient, sometimes among high-risk patients, they give, anticoagulation. Maybe NOAC will be an issue in this kind of patients. And the mean gradients of the balloon expandable valve was not superior to surgery, similar, but Mr. Reardon is here, and he will explain maybe the other results of the evolutar study also. So main results, both TAVI and surgery were associated with similar and low clinical event rates. Difference in the primary composite endpoint rate, which favored TAVI at 1 year, were attenuated after 5 years, but other important endpoints were either similar for both therapies, favored TAVI, especially for new onset atrial fibrillation and serious bleeding, and favored surgery for mild paravalvular and valve thrombosis. So the Evolute Low Risk Trial, 4-year outcomes, when we look, it's designed as a real-world trial where each site's heart team determine patient risks and minimize exclusions after consult. So when we look at only 23 of patients were below 70 years of age, but this trial also showed significantly better mean gradient and effective orifice area and index effective orifice area with Evolute TAVI at all follow-up time points. And 26% relative reduction in hazard for dead or disabled stroke with Evolute TAVI versus surgical aortic valve replacements here. The all-cause mortality was better in TAVI group, and significantly less mean gradient and severe patient prosthesis with Evolute TAVI versus surgical aortic valve replacements. So what are now hot topics in 2021? One is the commissural alignment for coronary reaccess and the coming new generation valves. I will speak a little bit about these points. Why is commissural alignment important in TAVI? Tendency to do TAVI in younger population, appropriate implantation technique will allow future coronary access. So commissural alignment may reduce risk of acute coronary obstruction during TAVI, and especially in valve TAVI procedures. Increase likelihood of redo TAVI by reducing risk of sinus sequestration and coronary obstruction. May have a long-term impact on durability because increased halt or gradient with misalignment. Basilica is not feasible if commissural post-phases to coronary osteums, and all valve manufacturers are now focusing on this topic. So what are the new generation systems? MyValve is a real game changer in balloon expandable valve technology with intermediate and extra large sizes. And Octacore is much more superior game changer because of its very important foreshortening property. And commissural alignment will be accurately done with the Octaline technique. And the next generation Evolute FX is very, very important because of its much more flexible delivery system, and radiopaque markers provide a reference for deployment depth and commissural location. And Allegra will be very good option for the valve-in-valve procedures. And porticonavitor will be very important about increased sealing zone and reducing for paravalvular leaks. And Duraver is the next generation balloon expandable valve with large cells and a good commissural alignment and very low gradients. And Gene valve for pure aortic regurgitation, G valve for pure aortic regurgitation, but because of their inadequate corresponding annulus diameter size, maybe larger sizes are required. But for the pure aortic regurgitation, my volt transcatheter half series X large are very, very important. 30.5 millimeter and 32 millimeter and 35 millimeter valve is coming. And Kocaeli TAVI system is a new TAVI system, is a polymer valve and ultra long lifespan. The polymer valve has a lifespan of 25 years, a significant increase over the 10-year lifespan of traditional interventional bioprosthetic valves. This means very long-term durability. Here is an example of a Kocaeli system with type 1 bicuspid anatomy. And Vienna aortic valve is coming with different sizes. And tubercular optimum valve is the lowest self-expandable valve height and allows full access to the coronary artery disease and reduce risks of conduction disturbances and intra-ulnar leaflets and designed for valve-in-valve implantation. So I want to give also an example to you about a young patient, 55 years old, male with chronic aortic regurgitation. She was admitted to different clinics before and severe heart failure was diagnosed and has been follow-up severe heart failure due to chronic aortic regurgitation. Ejection fraction was calculated as 5 to 10%, and patient also discussed to be a candidate for heart transplantation and referred to our center for a possible TAVI. When we look at the area was measured as over 600 and 667.3 millimeters, as you see. Femorals are okay. But when we decided to use an extra large size of MyVol in this patient, so we should never forget that ideal valve sizing may be in the range of 5, 10 or 15% higher than the area derived annulus diameter to have a good valve opposition. So this is the importance of the intermediate and extra large size, and I am sure that new balloon expandable valve also will do the same with intermediate size and extra large sizes. So we decided to put a 32 millimeter valve, as you see here. You can see the initial valve position in annulus and dog bone appearance of the balloon and the valve. And the final aortography showed no regurgitation. So this patient will recover very, very quickly after 3 months. Ejection fraction was completely increased. You can see the post-procedural transthoracic echocardiography. And the final femoral arteriography showed, but at the end of the procedure, we show complete AV block also, then we put a CRT to the patients. So what are the home messages? Current TAVI devices are not designed to achieve commissural alignment, but newer technologies, especially MyVol octa-core, Evolut FX, Safian X4, and Duraver are coming. And most important changes are observed in the delivery systems and valve designs of novel technologies to facilitate commissural alignment for future coronary access. Although new systems are developing for TAVI for pure aortic regurgitation, sizing problem is still an important issue, and novel devices with X large size have important advantages. New generation octa-core, Duraver, Evolut FX, Kocaeli, and tubercular TAVI devices will be future stars of the treatment of aortic stenosis, especially in low and young risk patients. Thank you very much for your attention.
Congratulations, Dr. Kilic. Dr. Iano wants a short comment.
Congratulations. Let me tell you that as a clinical cardiologist, When I heard all these types of valves, I felt like somebody who is in a very expensive restaurant with a list that knows no one and cannot collect the type of wine to match with his meal. So we depend completely on the doctor who is doing the procedure.
It's true, but much more valve means much more food, and it will automatically decrease the price of the meal. So these technologies are coming, and we should follow up all these technologies. Especially if we want to do TAVI, relatively younger population, I fully agree. For example, in our country, we are definitely following the recommendation of the European Society of Guidelines for the age limit. 75 is a good limit. Maybe 65 in the American Society of Cardiology Guidelines should be discussed in our countries. But when we look at the ACC guidelines also carefully, why 65 years old? Because of the inability of the current risk scores to find the exact risky patients. So that kind of patients are present in the real world practice also. And also new technologies and new studies are coming.
Thank you.
We will follow up.
Thank you.
Thank you very much.
Dr. Dardas.
Yes, congratulations, an excellent talk. It reinforces the idea is not only the age, it's the whole spectrum. We have to see the patient with all the problems. I saw with interest this last case you showed with severe AR and low ejection fraction, and we had a similar patient with severe AR after a failed Ross operation. It's a relatively young patient with ejection fraction of 10%, and nobody would touch her, no surgeon would touch her, and we did TAVI, despite of the young age. She did very well. Now she has an ejection fraction of more than 50%. So we need to individualize, not only to see the age of the patient.
Yes.
Congratulations.
Thank you.
Bear in mind, they add to the age in America that they less than 65 are going to live 20 years or more. And the average life expectancy for a woman in the U.S. right now is about 86, 87. For a man, it's about 83, 84. So if you add 20 years to 65, I think that's how they got there. So they're really, age is nothing but a surrogate for how long you should live. You know, if you're 65 and we don't think you're going to live 10 years, it doesn't matter what your age is. It's how long are you going to live. And it's just a surrogate for survivability.
Yeah, very important point. Thank you.
Thank you very much.
Thank you.
I would like to move ahead and call for the next last